Good morning, Dr. Kamini.
Good afternoon, sir. Thank
Good
you. Thank you for taking time to be with us today.
No. For you, ICMR.
Kamini, afternoon, sir.
Oh, good afternoon, Dr.
Everyone.
Kapila. Good afternoon, Nitin.
Good afternoon, ma'am.
Start the meeting now. So a very warm welcome to all who are joining us today for this very important webinar on bringing technological innovations to bedside for improving antimicrobial prescriptions, which ICMR is organizing on the occasion of World Antibiotic Awareness Week. I also welcome all the experts and distinguished speakers who have agreed to be part of this very important webinar. So as per the Lancet report, which was published this year, 1.25 million deaths in 2019 were directly attributable to AMR, and another 4.95 million were found to be associated with AMR. And these are pre-COVID numbers. Extensive antimicrobial use during COVID could have done further damage to this existing disease burden. So antimicrobials are arguably one of the best success stories in the history of medicine, and the advent of antibiotic era with the availability of effective, non-toxic, broad-spectrum antimicrobials brought immeasurable benefits to public health. The ability to treat infections early without identification of the causative agent resulted in saving countless lives and enabled many avenues of modern medicine, such as surgery, premature infant care, organ transplantations, cancer chemotherapy. However, we are now witnessing rising antibiotic resistance, and the emerging AMR is actually eroding these benefits. We are witnessing indiscriminate use of broad-spectrum antimicrobials, which are feeding the rising MDR rates, which we are seeing from ICMR data. And infections with MDR pathogens, as many of my colleagues who are here with me today would agree, that they are very difficult to treat and also are linked to high mortality. So tackling this antimicrobial crisis will require multifaceted approach that includes development of novel antibiotics and the practice of antimicrobial stewardship. While we need new drugs to take effective measures and use, but we also need steps to use judiciously what we already have. ICMR has released many guidelines in the past, which can help hospitals establish antimicrobial stewardship programs. We have also released treatment guidelines. And today we are sharing with you a mobile application, which is a downloadable treatment guideline for this year. And all these guidance documents are actually based on the tertiary care data and should only be used as a reference document. And all hospitals should actually strive to have an antibiotic policy which is based on their antibiograms. So we urgently need efforts to streamline our prescription practices and make deliberate shift from excessive reliance on broad spectrum antimicrobials to using narrow spectrum antimicrobials. There are various factors which make it challenging in our hospital settings, and the most important being the high infectious disease burden and non-availability of the diagnostic support. So in today's webinar, we have gathered distinguished experts in the field to deliberate on how we can improve the specificity of antimicrobial prescriptions in Indian hospitals in spite of these challenges. Now we will start with the first session, that is the challenges of rationalizing antimicrobial prescriptions in clinical practice. And I request Dr. B.K. Rao and Dr. Camilla Rodriguez to please chair this session. Just a brief introduction of both the chairs, although both of them are very well known in their field and they need no introduction. Dr. B.K. Rao is a critical care specialist, medical administrator, and a chairman of Board of Management of Sir Gangaram Hospital. He is also former chairman of National Accreditation Board of Hospitals. For his stellar service, he has been awarded Padma Bhushan in 2009 by Government of India for his contributions in medical science. And also he's one of the earlier supporters of the antimicrobial stewardship program when we started it in ICMR. So I really acknowledge his unconditional support to the ICMR initiatives. Dr. Camila Rodriguez from Hinduja Hospital is a well-known consultant microbiologist and is also a chair of Infection Control Committee. Dr. Camila's work on tuberculosis is a very important contribution to the TB disease in India. And she has trained a large number of microbiologists, doctoral candidates, and clinicians. Her research has resulted in more than 350 publications on various aspects of TB. And we are really glad to have Dr. Camila's expertise available to us from time to time, and for her interest in antimicrobial resistance and hospital-acquired infections. Over to you, chairs. Dr. Rao, you are muted, I think.
Thank you, Dr. Kamini, for your kind introduction. And on behalf of my co-chair, Dr. Camila Rodriguez, I welcome all the participants. We start our first session, and the first session is on challenges of rationalizing antimicrobial prescriptions in clinical practice. We have 4 distinguished speakers. We will be introducing them, and for the speakers, they each have 15 minutes, and we request them to stick to their timings. I invite the first speaker, Dr. Nitin Bansal, to speak on why do we need to improve our antibiotic prescriptions, data from labs and bedside. To introduce Dr. Nitin is an infectious disease physician, practices at Rajiv Gandhi Cancer Institute and Research Center, Delhi. He has 7 years of experience in this field. He's also working as a consultant with ICMR on antimicrobial stewardship program. Dr. Nitin, your time starts now.
Thank you, sir. I'll start sharing my screen. I hope my screen is visible.
Yes.
Yes, we can see. Can you make it full screen? Oh, okay.
I have made it.
Thanks.
So I've been asked to speak on why do we need to improve our antibiotic prescriptions from what is the data from labs and bedside. I do not have any conflicts of interest. I will be discussing basically 3 points, and I will be emphasizing on the knowledge about the local data, which is needed to improve the antibiotic prescriptions. I will be using the data from the ICMR annual report, which was released few months back, which gives us the information about the microbial spectrum and the susceptibility reports throughout India. Second issue which I will try to discuss is prescription of antibiotics when they are not needed, and the de-escalation. Why do we lack in de-escalation? So I will be using some of the cases which I see on a daily basis to emphasize my points. Case 1 is a 42-year-old male who has a non-Hodgkin's lymphoma and was given chemo 20 days back. He had come with fever, cough, respiratory distress, and he's got hypoxia requiring oxygen. He's been started on antibiotics, piperacillin, tazobactam, azithromycin, and the viral panel which was done had showed influenza H3N2. Now he's been continued in his therapy. Day 7 into ICU stay, he goes into shock and gets intubated. He's got a central and a Foley's catheter since admission. Now the ICU doctor intensively suspect that the patient is having most likely a CRBACI, and he recites the line and sends blood cultures and starts on meropenem and vancomycin. So the question is, are these empirical antibiotics right for a CRBACI patient in a septic shock who is admitted in an Indian oncology ICU? Now, if you look into the guidelines or look into the international literature which is available, what should be the empirical antibiotic to start in this particular patient? And this is one of the apps which we commonly use. I myself use this. In fact, this is the snapshot from my own mobile, which say that the common bugs are coagulase negative staph, staph aureus, candida albicans, non-albicans species of candida, enterococcus, and for oncology they say E. coli, enterococcus faecium, and viridans streptococci. And these apps actually recommend us to use vancomycin and cefepime. But are they actually useful in Indian settings or not? We will see. But if you look into the Indian data, this is from the ICMR annual report, which also gives us the report of healthcare associated infections. This is the flowchart from the bloodstream infection, that is catheter related bloodstream infections. We show that the predominant organisms are gram negatives, close to 3/4 of them, followed by gram positives and then fungi. Among the gram negatives, they are Klebsiella and Acinetobacter. So clearly, if you are going to go by the recommendations which are given by the Western countries, you are going to miss the most common bugs, and probably the patient may not survive by the time the culture reports come. So we need to change our practice in that way. We need to know our local data before we initiate the empirical antibiotics. So coming to the ICMR Antimicrobial Resistance Surveillance Network, which basically comprises of 24 centers, 20 regional centers and 4 nodal centers. As you can see from the photograph, they actually involve from the most part of the country. Actually, almost every state is being represented in this network, and they have been tracking resistance since 2013, and also of late doing the genomic study to understand the genomic pattern of the resistance. So in the recent report, which studied nearly 1 lakh isolates, 95,000 to be precise, as you can see, most of them are predominantly gram negatives, and in the ICU, it is basically Acinetobacter, which is the most common bug. So this is something which we need to know when we decide on the empirical antibiotics in a sick patient in ICU. Coming to again a similar second illustration, just to emphasize my point again. 22-year-old male who has been admitted with proven human metapneumovirus pneumonia. This is which I saw last week. Gets intubated on day 3. Now day 9 into his ventilation, he develops fever, hypotension, and increased ventilator requirement. An intensivist suspects a diagnosis of WAAW and starts empirical antibiotics. Now, the 2 international applications which guide us into empirical antibiotics for nosocomial pneumonia suggest us to start stress on covering MRSA, that is, and start vancomycin, and also to cover Pseudomonas, which they recommend to cover by ciprofloxacin, levofloxacin, or an aminoglycoside. Both of them basically give similar sort of a recommendation. But when you look into the Indian data, again from the last year's report, this is from the lower respiratory tract sample. The predominant organism is Acinetobacter baumannii, followed by Klebsiella and Pseudomonas aeruginosa. These are the top 3 pathogens. So if you are going to go by the earlier Western data, again you're going to miss most of the bugs. And again, by the time report comes, the patient may not even survive or might further worsen. So, and we know that the gram negatives from the report itself, the resistance pattern is quite worrisome. Resistance to carbapenems among Acinetobacter is alarmingly high, close to 87.5%. Whereas in the in E. coli and Klebsiella, it actually comes at around 40 to 50%. In E. coli, 40%, and in Klebsiella around 55%. So we need to cover these bugs when we are treating hospital-acquired pneumonia empirically at least. This is from the ICMR latest guideline, which say that if there's a late onset HAP or a WAP, then we need to cover the carbapenem resistance bugs by giving these antibiotics empirically by the time the culture report comes. So we are also fascinated by saying that we have a lot of newer antibiotics coming in. This is just a small list of the newer antibiotics which are expected to come. Some of them have already arrived. Some of them may or may not come also. But question is, will they work in Indian settings or not? So the answer comes from the genomic data, which was also released in the recent annual report. And when we see the genomic surveillance of the E. coli, we see that the most common ESBLs was CTXM1 and MC was CIT, but the most common carbapenem resistance was metallobutyllactamase, IMP being the most common and closely followed by NDM1. KPCs and OXAs were not that common in the E. coli study. Then looking into Klebsiella also, again, most common carbapenem resistance gene was OXA48 followed by NDM1. KPC and others were quite less common. Again, for Pseudomonas also, out of the 222 carbapenem resistant isolates, the predominant mechanism of action, which was quite peculiar from the rest of the world, is that there was a lot of presence of NDM in the Pseudomonas also. So drugs which are needed to develop, which need to work for Pseudomonas also need to work against the metallobutyllactamase. And similarly for Acinetobacter also, although OXA23 was the most common, but most of them co-harbored NDM gene as well. So all these newer antibiotics, only few of them are going to work in India. Rest of them may not even work in India. So we need to be, when we talk about newer antibiotics, we need to make sure that whether those antibiotics are going to work in the Indian settings or not. This is something which we need to understand from the local or the data which come from our own country. Coming to the second issue, which I'll try to discuss is when there is lack of evidence of an infection, still we give antibiotics. So illustrating that with another case, 34-year-old male who gets admitted with COVID pneumonia, proven COVID pneumonia on day 6 of his illness. He's hypoxic. He required some oxygen also, and he was at home. He has not taken any medical help, in the sense he was not hospitalized, and has come straight to the hospital. So apart from giving COVID therapy, steroids, and Clexane, will you give him antibiotics or not? So to answer this question, the literature said, how common is co-infection in COVID pneumonia? This is one of the meta-analyses published in 2020, which showed that the presence of co-infection in a patient with COVID-19 was close to just 7%. And whereas in another meta-analysis showed that the presence of COVID-19 co-infection in a COVID-19 patient was around 3.5%. Both these papers concluded that the use of empirical antibacterial therapy was actually not needed in patients who were admitted with mild to moderate COVID-19 pneumonia. But so bottom line is that we do not need, but we all know how many antibiotics are prescribed to these kinds of patients and how antibiotics are misused. And not only antibiotics, they were prescribed quite broad spectrum of antibiotics, which actually belong to a WAAW or reserve category as per the WHO classification. So when it comes to practicing evidence-based medicine, we all feel proud we practice evidence-based medicine. We all do that. But when it comes to not doing something for which there is no evidence, we generally take a backseat and just do it out of fear. This is something which we need to understand and change our practice. We need not prescribe antibiotics out of fear itself. Now, coming to the third and last issue regarding de-escalation. This is something also which we are not taught in our UG days and PG days. And so we are not in a habit to de-escalate patients. This is how normally clinicians behave, at least in my hospital. A diabetic patient who has got CA ovary, who comes after chemotherapy, comes with high-grade fever and hypotension, and has been given meropenem and teicoplanin after sending cultures. Understandably, she has come with septic shock most likely, and she improves in 48 hours and is getting shifted to the ICU, out of the ICU to the ward, and the culture report has come back by now. So what happens is, as we know, ideally we should be de-escalating the patient to third generation cephalosporin or a BLBLI. But what happens is how a clinician reacts is that we'll just tick that my patient is on meropenem. We'll just tick that report. He say meropenem is sensitive, so I will not change, and we'll just continue meropenem. So we do not practice de-escalation that much. So, I mean, what I want to say is that we need to be aware of the local guidelines. We need to be vigilant about local settings and scenarios and take this into consideration while deciding empirical antibiotics for our patients. That's why it is very important to understand to gather the culture reports, form an antibiogram, and form an antibiotic policy for your own hospital based on your own microbial spectrum. And then we also need to understand that we have to get out of habit of practicing giving antibiotics for out of fear, just in case infection, just in case bacterial infection. If there is no evidence, then we should stop antibiotics or de-escalate care. Again, as a part of our PG program, we should inculcate the habit of de-escalation of antibiotics or de-escalation of care itself. When we know that the culture report has come and narrow spectrum antibiotics can work as well as the broad spectrum antibiotic can. Thank you.
Thank you, Nitin. That was really excellent and succinct.
You covered.
Are we taking questions now? Dr. Rao, should we take questions now or keep it for the end?
You know, towards the end, what happens is people forget and...
okay, so maybe we'll allow one question.
Yeah. And then if there is something at the end, we can take it up.
Okay, but there are no questions in the...
we will have questions in the chat box only.
Okay, fine.
Oh,
so
yeah.
Currently there are none.
Check the chat box and then you can take the questions.
Sure, currently there are none. So we'll go on to the next presentation. How do we reach a syndromic diagnosis in infectious diseases? This is being addressed by none other than Dr. Ram Gopalakrishnan, who's a senior consultant in infectious diseases at the Hospital, Chennai. He has 34 years of experience in this profession, and he's also a member of the Tamil Nadu Medical Council. He's a chair, and more importantly, he's chair of the ICMR expert group on treatment guidelines for use of antimicrobials. Ram, the floor is yours.
Kindly unmute him.
Okay, can you hear me?
Yes, we can hear you, Dr.
Okay. Some issues with my internet connection. So just give me a minute while I pull up my slides. You'll have to enable me to share my screen.
Dr. Kamini, that has to be done from your side.
Yeah, we are taking care of it, sir. Just yeah, you should be able to do it now, Dr. Ram.
Okay. Okay, there we go. Hope my slides are visible to all.
They're visible. Yeah. They're visible. Thank you.
Right. So I've been asked to talk about how do we reach a syndromic diagnosis in ID. And really, that's like going through the entire textbook of infectious diseases, at least the first volume. Traditionally, our textbook of ID is in two big volumes, and that's one entire volume. But I'll try to run through things in about 15 minutes or so. So what is a syndrome? A syndrome is not a diagnosis. It is basically a constellation of symptoms, signs, and laboratory tests, which ultimately leads to a clinical diagnosis. Importantly, it is patient-oriented. You don't take a syndrome out of the textbook, and you certainly don't take it from a microorganism. Patients present with syndromes, and it's up to us to figure out what disease they have or what microbe is causing that. A syndrome usually leads to a differential diagnosis, and no patient comes in saying they have an infection. So this could be an infection, and it could certainly be a number of non-infectious etiologies. Most importantly, in many situations, a syndromic diagnosis can reliably predict microbial etiology and direct management, even when you don't establish that etiology. Just simply, for instance, somebody presents with community-acquired meningitis, chances are it's a pneumococcus, a meningococcus, or perhaps one or two other organisms. So making a syndromic diagnosis is very valuable, especially in a resource-constrained setting where you may not have good microbiology support available. A syndrome facilitates production of a guideline, and that is what ICMR has done and is attempting to progress further, because you can neatly classify the entire textbook of medicine and certainly infectious disease into syndromes and tell clinicians what they need to do. It is also very critical to antimicrobial stewardship, to start appropriate antibiotics and to stop unnecessary ones. For instance, if you diagnose a syndrome whose etiology is largely viral, as we'll see, you can stop the antibiotics. Unfortunately, bedside clinical teaching, certainly in infectious disease, is not oriented to syndromic diagnosis. We focus on diseases, we focus on organisms, but that's not how we end up seeing patients through most of our career. Some general principles in evaluating infections. Now, it's just like neurology. I'm sure in neurology, you were all taught, where is the lesion? In other words, what is your clinical localization? Similarly, in infectious disease, what is the syndrome? And then you look at what the microbial etiology, depending on what the answer to one is, you may or may not find the microbial etiology, you may not even want to look for it sometimes, but it's critical to follow this two-step approach. Remember, the response to a fever is an evaluation, not antibiotics. Doing it in reverse is why we have this whole problem of AMR today. Cultures before starting antibiotics. That is very important, because if you don't culture, then you're left with a problem. If your cultures don't grow and you don't have a syndromic diagnosis, antibiotics reduce culture yield by almost half, and therapy is not as important as diagnosis. Somebody said the most important thing in medicine is a diagnosis, not therapy whatsoever. So you don't jump into therapy, make a diagnosis. So if you're sitting in the outpatient clinic, like the vast majority of doctors who treat infections today, these are some of the common syndromes you'll come across. And I'll just take one of these for evaluation. For instance, if you're seeing a healthy female with a sore throat for the last 3 days, there's some temperature, a congested pharynx, and no cervical lymph nodes. Note the exudates on the tonsil, which you can easily see. So what syndrome does this patient have? The acute pharyngitis syndrome. So what is the correct approach? You can do a number of things. You can start various antibiotics. You could do a throat culture, or you could do a rapid streptococcal antigen test and follow it up with a throat culture. These are all open to Indian clinicians. And I would bet you most Indian clinicians would probably start an antibiotic right away. Is that the right thing to do? Well, if you look at the causes of the acute pharyngitis syndrome, it is largely twofold. It's either the streptococcus or it is a respiratory virus. We don't care which virus, anything from COVID to influenza, we don't care. Most of these things are self-resolving. Occasionally, you may have diphtheria or a sexually transmitted disease, but largely what you want to know when you see acute pharyngitis is this streptococcus or is this a respiratory virus? Now, why is group A strep important? Yes, some of these patients may go on to issues like quinsy, to local suppurative complications, but the most important long-term complication is acute rheumatic fever, which is classically seen in children between the age of 5 and 15. So that is the real reason why you want to diagnose group A strep. And it's important to realize that you can make this diagnosis clinically. There are several features which actually favor a viral etiology. You can see them on the right. If you have eye involvement, if you have a running nose, if you have cough, very interestingly, if you have cough, you're not likely to have an isolated group A strep. And certainly if you have an exanthem, etc., it's unlikely. On the other hand, a typical age or patchy tonsillopharyngeal exudates, cervical lymph nodes, these would all favor a bacterial, namely a group A strep etiology. So when you come across the acute pharyngitis syndrome, you do what Dr. Center has published. On the right, you see the Center score, which gives you a scoring system to base your diagnosis on. If your score is 0, it is not going to be bacterial. It's largely viral, no further testing or antibiotic. If your score is 4, in other words, somebody with all of those features, fever, tender cervical nodes, tonsillar exudates, etc., it is highly likely to be bacterial. You can even dispense with the test. You can straight away treat for group A strep. So treating for strep throat empirically is really not the right approach in the majority of patients, certainly not if your center score is low. So when you have a patient with the acute pharyngitis, what do? Somebody with very typical features of viral infections, don't even test. Under 3, don't even test. So typically, we don't have strep screens readily available in most parts of India. So you would go ahead with the throat culture. If that is negative, don't treat. If that is positive, you treat. Now, even in the Western world, this is not followed. You can see here that large numbers of patients who went to doctors for their pharyngitis actually got antibiotics. So there's a big disconnect between what the evidence and what the guidelines say and what we actually do in practice, which is the reason why we have this huge AMR problem today. And once you do diagnose pharyngitis, you don't need to reach for a big gun to treat it. You can treat it with penicillin. Benzathine penicillin, a single shot is my favorite antibiotic, or an oral penicillin. You certainly don't need to broaden your spectrum unless there's an issue like allergy. So as you can see, making a syndromic diagnosis clearly helps you both diagnose and treat these patients easily. Now, what about the acute febrile illness? This is another very important reason why patients present to doctors. Now, when they come in with fever for 2 days, that's really the difficult issue. You test, you know nothing, you just wait and watch, etc. And this interesting study from Chennai looked at this issue. They studied about 200 odd patients. They excluded patients who had focal sepsis. In other words, they had a pneumonia, a soft tissue infection, a UTI. You don't get into the study. And they looked at how you approach them depending upon the day of fever when they came in. They changed the test based upon the day of fever, day 5 or greater, basically looking for typhoid fever. And most importantly, patients came on day 2 or day 3. That's when that's a really clinical soft spot. You test, you not, etc. And you can see here that most of the time, if they come in, these patients with acute febrile illness, it's a non-specific, or they didn't make a diagnosis, probably viral in this situation. And what is important here is what I've put in a box. 75% of these patients defervesce without investigation. So acute febrile illness, if they come to you on day 1 and day 2, chances are high that they'll get better on their own if you can't make a clinical diagnosis. And certainly, at least more than half of them got better without antibiotics. Now, acute febrile illness has been studied in Africa as well. This is in African countries where malaria is endemic. And even here, they found in children viral diseases were the biggest cause of acute febrile illness. Uncommonly, did you have a bacterial illness? Malaria obviously can be looked for readily, perhaps with a rapid antigen test. And therefore, much of the time, we use antibiotics unnecessarily in this patient. Much of this is viral. In India, much of this may be due to mosquito-borne diseases such as dengue or upper respiratory infections. You don't need antibiotics or tests in the majority of these patients. This study from Pune actually did dengue or malaria tests on all patients who came in with acute febrile illness, and they found that making a diagnosis actually helped you reduce antibodies. So there's perhaps a take home in these points. Acute febrile illness, perhaps the 2 tests that you really need to do are testing for malaria and dengue. If that's negative, don't use antibiotics. So this is kind of an approach to undifferentiated fever. Day 1 and 2, antibiotics unnecessary. Day 3 and 4, get a white count, malaria test, etc. Day 5 onwards, look for typhoid. One more syndrome, which I'll discuss, where we usually use an antibiotics. You can see that this gentleman has an infiltrate, cough, but normal saturation. So you're going to treat this patient as an outpatient. You don't need to admit this patient. Now, what will you test this patient with? Do you need to test? Are all these tests really helpful in deciding whether to treat and how to treat this patient? This is what guidelines say. The only test you need to make a diagnosis of pneumonia is a chest X-ray, and the only test you need to decide whether to admit or treat as an outpatient is a pulse oximeter. You don't need anything else. You don't need blood cultures. You don't need sputum cultures. And the reason for that is we already know what causes pneumonia. You don't need that culture to establish the diagnosis. As you can see here, the common causes of pneumonia are either streptococcus or any number of respiratory viruses. Most of them don't need treatment if you're not hypoxemic, and occasionally you may have an atypical pneumonia syndrome. So if you reliably know what's causing pneumonia, why bother with tests like sputum, which have a long turnaround time, often reflect salivary contamination? And similarly, the treatment algorithms are based upon where you are. If you're an outpatient without comorbidities, all you need is a narrow spectrum drug like amoxicillin, doxycycline, or macrolide. In India, we have a fair amount of macrolide resistance in pneumococcus. With comorbidities, you need a beta beta-lactam, like say amoxiclav or cephalosporin, with a so-called atypical agent coverage. We don't use quinolones in India for fear of missing tuberculosis. What about syndromes that put you in the hospital, say acute meningoencephalitis? Somebody comes in with fever, neck stiffness, altered mental status, you suspect meningitis, you may or may not want to do a CT first. You do a CT if there's papilledema or if there are focal signs, and you give a single dose of antibiotic, perhaps acyclovir. After drawing cultures, you proceed with a lumbar puncture, and we know reliably what causes meningitis in India. Pneumococcus, less commonly Neisseria or Haemophilus. If they're elderly, diphtheria. If they're neonates, group B strep. But importantly, some of these tropical pathogens like scrub typhus, leptospirosis also need to be looked for in the Indian scenario. And this is the usual empiric antibiotic regimen that we start: ceftriaxone, doxycycline for atypical agents, ampicillin for listeria, acyclovir till we rule out HSV. And then we proceed based upon the CSF formula. And if you're fortunate enough to get a culture, proceed accordingly. We looked at the microbial etiology in many of these patients, and we found that this approach is quite useful, giving a combination of ceftriaxone, doxy, acyclovir, with or without ampicillin, and then proceeding further based upon the CSF formula, whether it's neutrophil predominant, lymphocyte predominant, etc., and making a diagnosis. So as you can see here, syndromic diagnosis is really the bedrock of good clinical practice of infectious disease, and most of us would have learned this during our undergraduate or postgraduate training. Once you accurately identify the syndrome, standard protocols are in place. Just open the ICMR guideline, open your Harrison's textbook, whatever it is, and you can start therapy. Now, if you're following a protocol, remember that should be relevant either to your country or to your local practice setting. It could be a state, it could be your hospital. That is why it is very important not to blindly copy and paste from international guidelines. Bedside availability is very important. If you're a practicing clinician, you don't have time to open the textbook at the end of the day, and certainly your patient would have left. So it should be available, not even on a desktop, on your smartphone. And that is what ICMR is working on, introducing its guideline into a smartphone. And this is really critical. As you can see, if you diagnose viral syndromes, getting rid of that antibiotic can be done with great confidence. Thank you very much. That's my last slide. I will stop sharing here and hand it back to the.
Dr. Kamila, there is a question there, if we can take it up now.
Yeah, somebody's asked that it's often cheaper in India to prescribe empirical therapy than going for expensive syndromic diagnosis. I think that question is fairly fair. And Ram, would you want to take it in a minute? You've actually answered it in your talk, but. Ram? Anyway, since Ram can't hear us, I think clearly this is a case in point that these syndromic molecular tests are fine, they're great, but there's certain indications where you use them, and these tests are useful, are ideal only when used in the context of thoughtful clinical evaluation. If you just do it willy-nilly on everybody, you're going to land up with more information than you know what to do. Thank you.
So we take up the third presentation of the day, and I invite Dr. Tanu Singhal for the presentation. on decision on antibiotic therapy, interpreting lab result. Dr. Tanu Sundar is a pediatrician and she is the ID consultant in Kokolaban Hospital, Mumbai. She's a renowned pediatrician and currently associated with Kokolaban, as I said, as a consultant in pediatrics and infectious disease. Dr. Tanu.
So thank you so much. Thank you, Dr. Walia, for giving me this opportunity. And I hope my screen is visible.
Yes.
Okay. So in this presentation of mine, I'm just going to be focusing on cultures. Because remember, when we make a diagnosis of infectious disease, we can make it on the basis of a hematology, some on your cytopathology, histopath, molecular tests, serology, etc. But for the purpose of this presentation, I'm going to just focus on cultures. So the first thing when you look at a culture is to look at what organism have you grown. And when we look at blood cultures, we must understand that there are certain true pathogens. So if you get a gram-negative bacteria or you get candida or you get staph aureus from a blood culture which is obtained through a peripheral prick, then it is a true pathogen. Of course, sometimes you can also get organisms like Burkholderia cepacia, which may be coming from the antiseptic used to clean the skin, but that is an exception. And the other important point is that what you grow in the culture should fit in with your clinical setting. Now, it's sometimes or more often than not, you actually get other bacteria, and these are contaminants. And commonly, this is including coagulase negative staph, diphtheroids, and as I said, Burkholderia may be a contaminant. And some of the characteristics of these contaminants are that they may grow after 48 hours. And since we always send a set of blood cultures or we send 2 sets, only 1 bottle is positive. And they don't fit in with the clinical spectrum. And it is very important to know these because so that you can decide not to treat these. And because if you treat these contaminants, you're overusing antibiotics. And then we have these colonizers which come from central line or arterial line samples, which are often sent in the ICU. And therefore, we must remember that when we are sending these samples, we must also send a peripheral culture to interpret the result appropriately. So, for example, if you have a CVP tip which grows staph hemolyticus, and you don't have any other blood culture positive for a coagulase negative staph, this is a colonizer and it does not merit therapy. Apart from blood cultures, cultures from non-sterile sites have to be looked for even more carefully in light of the clinical situation, because many times these are colonizers and they are MDR or XDR pathogens. And treatment of these pathogens will actually generate more resistance, increase cost of therapy, and cause adverse effects. And this is quite common in hospital ICUs to treat these pathogens. And these kind of cultures include sputum cultures or stool cultures in a patient who's already on antibiotics. So you have a patient admitted with a community-acquired pneumonia and he's already on oral antibiotics for 2 days, and then you send a sputum culture which grows Klebsiella or Pseudomonas. That is actually a colonizer. It's not the true pathogen. Urine cultures in catheterized patients have to be interpreted very carefully. So also endotracheal cultures in ventilated patients. Then sending swabs from open wounds is of no benefit. And similarly, sending cultures from indwelling drains are almost always colonizers. And in fact, there are some labs which actually accept catheter tip and endotracheal tip cultures, but these should never be sent. So before we actually look at the susceptibility, please look at the organism, the site from where the culture has been obtained, the clinical, and correlate with it with the clinical condition for you to, so that you can decide whether you are going to go ahead and treat that culture. Now, if you feel that the organism is relevant, then you will have to look at the susceptibility. And we all know that there are various methods for susceptibility testing, including disk diffusion, automated methods like Vitek or BD Phoenix, broth microdilution, yeast strip, etc. And the basic principle of all these methods is to pronounce organisms as either sensitive, resistant, or intermediate. And they do it by comparing the zone or the minimum inhibitory concentration to various breakpoints. And you generally have 2 breakpoints. You have a susceptibility breakpoint and a resistance breakpoint. And if it is the MIC is lower than the susceptibility breakpoint, it is sensitive. And if it is higher than the resistance breakpoint, it is resistant. And if it is between the two, it is intermediate. Now, these breakpoints are different for different antibiotics, different organisms, and to complicate matters further, they are different for different societies. So we must actually, we will discuss this more during this talk. And sometimes, you often hear people saying that, I gave an antibiotic and the culture came resistant, but the patient improved. And that is because of something which is called as the 60-90 rule. So if an organism is sensitive, your chances of therapeutic success are high. But if the organism is resistant, the chances of therapeutic success are not 0, they are even 60%. So if you have started an empiric antibiotic and your culture has come as a resistant organism, but the patient has clinically improved and you have effected a microbiologic cure, you may decide not to change the antibiotic unless the infection is at a critical site or the patient is immunocompromised. And when something is pronounced as intermediate, you can sometimes get away by treating these pathogens by using higher doses, especially if the antibiotic concentrates at the site of infection. Now, when we look at a culture report, we should not stop at just seeing whether it is sensitive or resistant. We have to also look at the MIC. And when you look at the minimum inhibitory concentration, don't compare absolute MIC values. You have to compare the MIC to the breakpoint. Now, unfortunately, these breakpoints are not available easily, and you can either get it from an app on a smartphone or you can get it from the internet for UCAST. And CLSI breakpoints are not readily published, but you can ask your lab. And if you're practicing infectious disease day in and day out, it may be a good idea to memorize some of the common breakpoints for common pathogens and common antibiotics, and interpret the MIC with respect to the breakpoint. So if you find a report which says that for a particular pathogen, piperacillin tazobactam is sensitive, see whether that MIC which has been given is just well below the breakpoint or at the upper limit. Is it sensitive by one society and intermediate or resistant by the other? And if you find that the MIC is just at the susceptibility breakpoint, then you might want to use higher doses and a prolonged infusion. It is also important to see how resistant a pathogen is. So for example, if you're looking at the carbapenem MIC and it says it's resistant, look at the MIC. If it is very high above the resistance breakpoint, you know that you will not be able to successfully use the carbapenem even if you use high doses. So this is just like a table which I have put to illustrate this complexity. So for example, for E. coli, if you look at piperacillin tazobactam, UCAST or new CLSI guidelines, 8 is the susceptibility breakpoint and 16 is SDD and 32 is resistant. And if you look at the new dosing guidelines which have come in, you should actually use, if you have a MIC of 4 or 8, you can get away by using maybe 4.5 grams 8 hourly over 30 minutes. But if your MIC is 16, you will have to use 4.5 grams 6 hourly, and that too over 3 to 4 hours. And you can see the discordance between the CLSI and UCAST meropenem breakpoints also, where you find that by CLSI, the susceptibility breakpoint is 1, whereas by UCAST it is 2. So if you have a meropenem MIC of 2, you would want to use a higher dose and as a prolonged infusion. And as we said, cefepime is another drug for which there is a discordance, because though your CLSI will say that 2 and 4 MICs are SDD, in real life, you cannot successfully use cefepime for therapy if the MIC is more than 1. So therefore, always look at the MIC. Now, with this basic knowledge, let us look at some scenarios. So let us look at Staph aureus. So when you look at a Staph aureus report, you first look at oxacillin and cefoxitin. If oxacillin is sensitive and cefoxitin screen is negative, it means it is a methicillin sensitive Staph aureus. And these infections have to be treated with either cloxacillin or with first generation cephalosporins. In fact, you should never use Vanco and Tico to treat these infections, and lab should not even report on the susceptibility. So if you can see this report from my hospital, they have not even talked about Vanco and Tico susceptibility, and this is something which we call as selective reporting. And you must also understand that not every antibiotic which is sensitive can be used. So though ciprofloxacin is pronounced sensitive, we do not treat Staph aureus infections with ciprofloxacin. Now let us look at this report. Here, oxacillin is resistant. So this is an MRSA. Now here, the most important thing which you have to look at is the vancomycin MIC if you're wanting to use vancomycin, because though the susceptibility breadpoint of vancomycin is 2, and anything 1 or even 2 will be pronounced as sensitive, if your vancomycin MIC is above 1, you will not be able to treat it successfully, and you will have to use alternative drugs for treatment, maybe daptomycin or ceftaroline, etc. Now let us look at this gram-negative report. Now, if you look at this is E. coli and you find that it is ceftriaxone resistant. So this is an extended spectrum beta-lactamase producing pathogen. And here you have to choose between different treatment options, and the common options are either a BL-BLI combination like piperacillin tazobactam or cefoperazone sulbactam or carbapenems. And the choice of therapy will actually depend on how much is sick the patient and what is the adequacy of source control and what is the BL-BLI MIC. Because if you have a very sick patient where you can't do source control and the BL-BLI or the BL-BLI MIC is high, you will have to use a carbapenem. So if you look at this report, you find that the piperacillin tazobactam MIC is less than equal to 4. So it means it is quite sensitive. If you look at the cefepime MIC, you find it is 2. And as I said earlier, though it is shown as sensitive in the report, it is unlikely to work. Amoxiclav is an issue because, when you see amoxiclav is an oral antibiotic, so people would be tempted to use amoxicillin clavulanic acid, but it is less likely to work in the setting of an ESBL pathogen. So when you have ceftriaxone resistant. And you should always look at TMP SMX susceptibility, because if it was sensitive and it is E. coli, that is an excellent oral drug to use. Now let us look at this report of Klebsiella. Here you find that it is carbapenem resistant. So here you have to make a decision about treating this carbapenem resistant pathogen. So the other information which you need in this patient is actually cholesterol susceptibility. You need to know the carbapenem MIC. You need to know what is the sensitivity to other drugs like tigecycline, minocycline, phosphomycin, amikacin. And if it is an enterobacterales, then you need to know the sensitivity to ceftazidime, avibactam, and aztreonam. So if you look at this report, you find that the carbapenem, it is resistant, but the MIC is 4. So here it is possible to use high-dose meropenem as an additional drug. And always remember that cholesterol susceptibility by Vitek is not reliable. So you will have to ask your lab to do it by broth microdilution. And, for CLSI does not give any cholesterol as sensitive. It is always intermediate because the drug itself and its penetration into various sites is not good. Tigecycline MIC is important to look at because the CLSI will give even isolates of an MIC of 1 or 2 as sensitive. But in theory, or in practical, if your MIC is more than 1, you cannot use tigecycline high dose to treat the patient. Important to look at phosphomycin MIC too, because if it is 16 or less, the chances of success are high, whereas if it is 32 or 64, the chances of success are lower. And what about this isolate where cholesterol is resistant? So now what will you treat? So you simply can't go and use trimethoprim sulfamethoxazole for Klebsiella. So you will have to ask for susceptibility to other drugs. And if ceftazidime avibactam is sensitive, it means it is the drug of choice for CRE if it is sensitive. But if you have this isolate of Klebsiella where your ceftazidime avibactam is resistant, you have an option of either treating with polymyxin, with phosphomycin or minocycline, or you can use a combination of ceftazidime, avibactam, and aztreonam, which will take care of the NDM and OXA producing Klebsiella. And here I must say that before you actually use this combination, you must check for synergy. And this is especially important for E. coli because many E. coli can be resistant to the combination because of altered PBP. So it is not enough to just detect the enzymes by expert carba or any other carbapenemase detection test so you have to check for synergy before you use this combination. And I would recommend this guidance statement by ICMR on treatment of carbapenem resistant infections. So finally, I would like to end by saying that look at the site of the culture and the organism. And if the organism is relevant, then scrutinize the susceptibility report, also look at the MIC and choose the antibiotic based on several factors, including efficacy against the particular pathogen, the site of infection, the host comorbidities, and also how low is the MIC below the breakpoint. And then use the correct doses and the dosing interval. And finally, always remember discordance between in vivo and in vitro susceptibility. Thank you so much.
Thank you, Tanu.
Thank you.
Sir, go ahead, please.
Yeah, thank you, Dr. Tanu. Can we take a few of the questions, Dr. Camilla? Because I
Yeah,
think few of them got collected.
Yeah, I think one would be, it would be desirable to have greater synergy between ICMR network, the AMR network, and respiratory virology and vector group. Antibiotics are wrongly used to treat respiratory infections, fosfomycin, etc. So that's true. That's just a point. The other question is, I feel more data collection should be based on patient clinical profile, which will guide us towards knowing the microbes of wards. Once we have this clinical data ready in a year, we can predict the organism and predict and give guided therapy. Tanu, they basically want to include in clinical data in the AMSR network. What is your impression?
Yes, I mean, because right now what we have is just data like in ICU, data coming in from the ICU, but we actually don't know how much of the pathogens which are represented in that data are true pathogens and how many are colonizers. So I think that differentiation is important.
No, so how do you propose that ICMR would you need a solid feedback, a solid to and fro on every isolate, because you would have to, as you feed your data into the AMSR network, it is incumbent on the labs feeding the data to say what the clinician felt.
I mean, I think we should not look at volumes. We should look at the, we should try and get more representative samples, because, even if we have representative 1,000 samples, I think that will be more important than having, let's say, 20 or 30,000 samples. Because I feel that a lot of data which is coming in from the ICMR may be colonizers in respiratory tract and urine, etc.
So what would your comments
be? I would recommend that it should be from the lab end. I mean, the labs which are contributing the samples should only provide those, which should enter only those samples in the AMR network which are true pathogens and not just colonizers.
No, but see, that is the whole problem. The labs are issuing these reports. The colonizing flora is going back to the clinician. And if the clinician is just treated, I'm not talking about ID physicians, the run-of-the-mill clinician is going to treat a colonizer. So it's going to be treated. So either you stop it with an active dialogue that, am I going to report it or am I not going to report it? Because that's the only way. Once you have a report in front of you saying, I mean, you spoke about cons, just so you have an MR cons, we have enough physicians outside who are treating their patients on one single isolate in a blood culture with vancomycin. So there is got to be a lot more give and take between the labs and the clinicians on every report. That has to be the norm, and only then can we feed the data into the ICMR portal,
Yeah, so I think it has to be done at the level of the hospital which is supplying the data, because it cannot be done at the ICMR, end.
Absolutely. Okay, I think we are running over time.
Anu, just one more thing. You said for MIC, is MIC available in all the reports? Blood culture reports and sensitivity reports?
Yeah, so I mean, most of the labs would, especially if they're using Phoenix or Vitec, they would probably give the MIC as a addendum to the report. I mean, our hospital does it, and I feel that other labs should also give it, but we must also remember that these are not exact MICs. They are like, it will say it's below 4, but it will not say how much below 4. But even that, I think, is definitely needed for labs to give that data, especially if you're treating critically ill and immunocompromised patients.
Okay.
One last question. There is a question. Is there a plan from ICMR to do research to develop breakpoint and MIC data that are relevant to Indian isolates? And we need to, at least we should try for priority pathogens. Kamini, would you want to take that?
So we, madam, usually follow the CLSI breakpoints. But
they're asking, would it be better for us to have our Indian?
I mean, if it has a significant advantage, and if our PIs and our experts recommend it, we can take up this exercise. That how relevant would that piece of work would be? I mean, other than what we are using, which is the CLSI.
Okay, and one
Dr.
last
Kamini, it
question.
needs to be
Yeah.
updated every time. It is not one time.
Yeah, it's
Yeah.
a yearly exercise.
I mean, we have had these discussions in the past in our expert groups, and Dr. Ori guides us on all these matters, and he feels that, and others also agree with him, that the CLSI breakpoints work very well with us, except for very exceptional situations where we have had Indian breakpoints included wherever CLSI breakpoints were not available.
Okay, there's just one question coming, Tanu. What is the role of rifampicin synergy with MDR-CLEP, and what is the role of checkerboard analysis? Quickly, we just have one.
So, I mean, I'll answer the first question, the second one I give to you, but there is really no role of rifampicin in gram-negative pathogens. For Acinetobacter, in fact, there was a randomized control trial which showed no benefit. So I don't think that is a way to go.
And I'll just take the checkerboard analysis is great to do if you have the facilities, and there's another way to look at synergy as known as PAP, and it's tough to do. So as of now, none of us are really doing it. If you want to do it on a project, but on routine basis, it really becomes difficult on a daily basis. Thank you. Okay, we are done with questions, and we are just a minute late. So our next talk is the person who's really worked behind. And I'm so happy to introduce Harpreet Singh. Harpreet is the head of the BMI in the ICMR, and he's really worked hard on getting the bioinformatics. He's a technical professional with 17 years of experience in data management and analysis. And we know him personally. He's been at every meeting. Harpreet, we really acknowledge your patience in all this medical jargon. And he's going to speak on how he set up the ICMR mobile app for treatment guidelines on antimicrobial use. Friends, Dr. Harpreet Singh.
Thank you, ma'am, and thank you, sir. And, thank you, Dr. Kamini. So, in fact, after listening to all these talks, I was feeling a little odd here because I'm going to talk on a little different topic. So, the thing is, let me start with what Dr. Nitin has just emphasized, that we need these guidelines for Indian settings. He has given a couple of cases. So we need guidelines, yes, definitely, because these guidelines, policies, and documents, these are very important for addressing larger public health challenges. And AMR is one of such large public health challenge. But as has been discussed, ICMR has developed these guidelines, which are going to be very useful in combating the AMR problem. And you will also agree with me that disseminating these developed guidelines to relevant stakeholders is equally important. Can we have the next slide? And one of the important and significant, so next please, Sonam, next please. One of the most important and significant ways of disseminating this guidelines and the information and the data is, I think something has stuck. Okay, so one of the important ways in outreaching is internet. So we started developing this app, and this app is available both on Android and iOS platforms. Okay, no problem. I can continue this. Okay. So now I'm seeing my own picture. Okay. So the first question is how to access this app. So if you look at the first slide, can you go back on the second slide? There is a QR code which is being circulated by the AMR network, and which is also being circulated on various ICMR social media and various other platforms. This QR code, if one scans the QR code, he or she can directly go to the page. This is the page where the person who scans the QR code will land, and here you will have access to both the Android version of the app and the iOS version of the app. So if one clicks on the Android, the app is available on Google Play Store. The top right image you can see, it is the screenshot of app which is available on the Android Play Store. And if one clicks on the Apple, because most of us have Apple phones, there you can just have to, because we have developed this using this progressive web app technology. So one has to add a home screen. So I have shown that button. Once you click on that button on the bottom of your web page, you click on add to home screen, an icon will appear. That icon will act as an app. Next slide, please. So this is what it looks on the Apple phone. So it opens up as an app, and when you click on the enter, click here to enter, you'll get the access to the contents. The contents are nicely arranged by Dr. Nitin and Dr. Kamini's team, and we have just coded this in various conditions like acute fever, sepsis. And when you click on that, each of the condition, a very detailed usage, diagnostics and instructions come in the guideline. Next, please. So this is something, please download this app either for Android or for iOS, and then let us know the feedback. But why I put this slide, because having information in digital form in the app or on the tablets is one part of the story. But if you ask, what I have seen with the physicians, it is not very easy for them to look at this information every time when a sample comes. So because if it is useful to you, we are ready to generate an API for this guidelines, so that when you have this lab report of the antimicrobial susceptibility testing or microbiology testing, the relevant portions, specific portions of the guidelines can be embedded into the report, so that when it goes to the physician, he or she can just have a look at the organism isolated, the sample, the condition, and the relevant portion from the guidelines. So this is what we are looking at. If it is okay, if it is required by the clinicians, we have everything and we can develop this API very quickly so that it can be integrated with the microbiology or the hospital information system. So thank you very much. This is all from me, and please install this app and let me know if there are any feedbacks. Thank you, sir.
One question is, what
Yes.
is API?
What is API? API is application programming interface. It is a little piece of software that we write so that machines can communicate with each other. The system which is generating reports can communicate with the system for the guidelines which is available at ICMR and fetch the relevant information.
And can some of the participants try and see if it's so, because Harpreet is here. So
Yes,
it seems so easy. Can you just see if it's working on your phones? He's told how to manage on the Android as well as Apple.
Please go on the first page. Second page.
Because we still have a couple of minutes, and it's nice if we could do it online. While Harpreet is here to guide us, because I'm sure.
Shall I
Harpreet next? Yeah, go ahead.
open the browser? Browser open karo. ठीक है, कोई भी AMRTG tg.icmr.org.in. Enter. So this is the first page. If it is visible, ma'am, so all of you.
Yeah. Can you just read out, Harpreet, the Google AMRTG?
AMRTG.icmr.org.in.
Thanks.
Ma'am, it is there on the last line is the link.
Oh yeah, okay, got it. Sorry.
So from this link, ma'am, you can go to the page which will tell you for iOS version and for Android. Next slide.
You just finished the talks.
So from here,
We'll have you.
Great, it's working for me, and I'm really technically challenged. So if I can do it, I'm sure everyone can. Thanks a lot, Harpreet.
Thank you, ma'am.
So you were able to download the.
Yeah, I could do it.
So it is an honor and a proud privilege for me to have with us here Director General ICMR and Secretary Department of Health Research, Dr. Rajiv Bahal. And he is a pediatrician and has had extensive experience in the public health. This is the first AMR meeting that he has had an having an opportunity to attend. So I request you, sir, to say a few words. So today we are having this webinar on bringing technological innovation to bedside for improving antimicrobial prescriptions. The challenge which we are facing in the country is that we have a excessive broad spectrum antimicrobial use, which is really feeding the MDR rates. And we are also seeing very high mortality related to MDR infections, especially during the COVID times and otherwise also. So that's why we are having this webinar on this particular area, how we can improve the specificity of prescriptions in daily practice. Over to you, sir.
No, thank you very much. And as you said, Dr. Kamini Walia, that the antimicrobial resistance is a huge challenge today. It's a global challenge. It could be the next big thing that we face as a health problem. I think you have all had these issues discussed in detail. And misuse or overuse or irrational use of antibiotics, not only for humans, but also for animals, is a huge issue that we have to sort. We have many task forces, many research projects ongoing, including finding out the surveillance for AMR, trying to find out for each state what are the local antibiograms, etc. But eventually, the solution lies actually in the hands of the clinicians and those who are able to prescribe antibiotics. And we really hope that these new advances, the guidelines that ICMR has issued, the new app that you were just, I think that was the app you were downloading,
Yes.
Which will help with the choice of antibiotics and improve rational use of antibiotics, would be something that would go a long way in trying to control antimicrobial resistance. Otherwise, we are in a very difficult situation where the pipeline for the new antibiotics is probably too slow and too little is there in the pipeline. And the pace at which we might lose the antibiotics may be much, much faster. So this is a pending disaster in case it happens. And it is a very good idea to do whatever we can as people who are clinicians, who are researchers, who are program managers, to make sure that no overuse, or at least we reduce this misuse and overuse of antibiotics. So I really hope this webinar was useful so far, and look forward to this panel discussion that you are having. You are going to have now?
Yes, sir. We are
Yeah,
going to have
I'll participate. I'll just listen in
Oh, sure.
for a while.
Okay.
And thank you very much. And thanks for everybody who is attending. I think there are a few hundred people there, 200 people. So very nice to have all of you. Thank you for attending, and please make sure that you take this message far and wide. Thank you.
Thank you, sir. So the previous session was chaired by Dr. Camilla and Dr. B.K. Rao. Sir, have we had a round of questions, or are there any unanswered questions that we would like to take up now, or can we move to the panel discussion?
We
Dr.
more or less answered everything. There's someone who said that a few of the tables may be incomplete, and someone said suggest having comprehensive guidelines for children. Otherwise, we're good.
Yeah, so on the comprehensive guidelines for children, we already have consolidated a group on pediatric AMR, and we are looking at with Dr. Tanu Singhal leading that, and Dr. Tanu Singhal was speaking today as well. And she is also a pediatrician, and we are looking at what is the data available and what are the data gaps. So once we have the clear-cut understanding of whether we have sufficient data to go forward, because there was a request to have a country-specific neonatal sepsis guidelines. and which we thought is important, but then the data is very different in the tertiary if we compare it with the community data. So once we have addressed the data related challenges, if required, we will initiate data collection from the beginning after understanding from the pediatricians what age group data is needed. So we are already in touch with Dr. Tanu Singhal for that. Dr. Camilla, was there any other question which you would like me to address? Okay.
No, I think we're done with all. Thank you.
Thank you. Thank you, Dr. Camilla. Thank you, Dr. Rao, and all the speakers from the previous session. Really appreciate your taking out from time out from your very busy schedule. This antimicrobial awareness week month, I think it's the activities extend across the month, and all of you are so busy. Still, you agreed to do this. We are really grateful for that. So now we move to the panel discussion. Dr. Sanjeev Singh and myself, we will be co-hosting this panel discussion. Thank you, Dr. Singh, for joining. And the panelists with us will be Dr. Rao, Dr. Camilla, Dr. Rakesh Lodha from AIIMS, and Dr. Leena. Over to you, Dr. Singh.
Thank you so much, Dr. Kamini, and congratulations to you to lead such a fantastic program. As Dr. Rajiv just now mentioned, that it is a public health and a global agenda. And it is so great to know that you have done phenomenal work. Thanks, Dr. Rajiv, for initiating again the dialogue and for surveillance, One Health, clinician's role and researcher. And it was our first meeting, and it was so great to hear you and look forward to your participation. So in the panel, we will have Dr. B.K. Rao, who needs no introduction. He's a critical care specialist par excellence. He is a Pad Bhushan and has been a chairman for NABH. So he has been done that for so long and has been a supporter for antimicrobial stewardship. Dr. Camilla is a name where everybody would like to be associated with, because the guidance which Madam gives for stewardship, for work in TB, for work in fungal, and for work overall in AMR containment is just phenomenal. We also have Dr. Rajiv, who is a professor at Pediatric Intensive Care, Rakesh Lodha, who is a professor at Pediatrics in All India Institute of Medical Sciences, and amazing 800 publications, and he's a specialist in pediatrics ID. And we have Dr. Leena, who's a regional head of Medicine Sans Frontier Access Campaign South Asia. Dr. Leena began her work on access to HIV/TB with Lawyers Collective, and is an Indian-based human rights organization. And thank you, Dr. Leena, for participating. So I'll quickly go, and I also like to thank Dr. Nitin and Dr. Ram, Dr. Tanu for a fantastic presentation. Really enjoyed listening to you. I'll quickly go to all four of you for a good rapid fire round. Just wanted to understand, we were talking about this app, we were talking about our own antibiogram, but we still depend on some of the guidelines from the developed countries. So what is your view? Should we depend, should we not depend? What would be the public health perspective and clinicians' perspective? So a quick round from each panelist.
Sanjeev, I think the question was answered by the first two speakers. And as we know that the kind of bugs we have, at least in our intensive care, are very different compared to what they have. We have very different antimicrobial resistance mechanism. We have very different antimicrobial resistance patterns. That means the incidence or the level at which we are at present compared to the West. And above all, which probably is unique in our own setup, is that all our patients who come to the tertiary care hospitals are already on a whole lot of antibiotics, and rationally or irrationally. So our hands get tied down because they are already on high-end antibiotic, including the polymyxins. So something that the Westerns never face. So that's my take.
Yeah, that's an everyday situation. Dr. Camilla?
I think Nitin adequately showed that with ICMR data that our country is reeling under a gram-negative predominance. And nowhere in the developed world, they're always talking about staff. So their guidelines are based on staff. Staff always comes first, and they're focused on MRSA. MRSA is about 30 to 40% of our staff. And if you look at the bigger picture, it comes to about 3 or 4% of our total bugs. So we completely different from the West with predominance of gram-negative, and the resistant mechanisms, as you'll hear, and Tanu has also stressed, are completely different. We are NBM, we have different affinators. So I don't know we can just take verbatim guidelines from the West at all.
Dr. Rakesh, what would be your perspective from your institute?
Yeah, I think we would agree with what has been discussed so far. I think I would just like to focus on more data from the community level. I think what's happening is that the data from tertiary care, and that's quite frightening. And once these data are in a public domain, I think it just strengthens the view of a person practicing with maybe limited access to microbiology to kind of use more higher end antibiotic. It's a typical clinician's dilemma about, whether to first focus on the patient. And if you tell us that, almost every organism is showing resistance to the first line or second line antibiotics, so people don't hesitate in starting the so-called reserve antibiotics. So that's one thing I think we need more data, and that should support more rational guidelines. The other issue would be more about, I think, focusing on better diagnostic services and trying to focus on de-escalation. So certainly whatever comes from the West would not be applicable. I think we need to have our own guidelines based on data. But I think the focus should be on tertiary. I think we are doing a lot, but in terms of gathering data, but I think the community level needs to be strengthened more. Thank you.
Yeah, very rightly said, Dr. Rakesh. I think it is important to have, most of this data is the tertiary care ICU data, and more of a community participation should happen. So, Dr. Leena, what would be your point of view?
Yeah, so firstly, just pointing out that I'm not a doctor, I'm a lawyer who's worked on public health for some time. And if you look at what's happened in drug-resistant tuberculosis, even with the WHO guidelines, what you learned is that Indian data and Indian, drug-resistant surveys that, for the first time the TB program rolled out, helped us understand that, India had to use both the new TB drugs and will continue to have to use more individualized regimens rather than a one standardized regimen. And I think this is where, the fact that we need to have this surveillance and data coming both from the community and hospital-based settings is really equally important. And I think what really is interesting about TB is it's translated into saying that we want the diagnosis to be available even in the private sector. And I think this is where I think we need to start discussing ways of implementation, moving from where we have data to how we're going to implement this, not just in the public sector or tertiary level, how we're going to, implement this at the community level, both in, public sector settings, but also in private settings. And I think that's the big challenge sort of that India has. Yeah.
Thanks,
Sanjeev, one more thing, Sanjeev.
Yeah,
not
sure.
only that, the antibiotics in the Western guidelines may or may not work. The availability of these antibiotics in India is also not assured.
Yeah.
So we just can't copy them for that reason as well.
Yeah, this inequitable distribution and why LMIC is always the sufferer, and we get the newer antibiotics after 6 to 7 years is not understood. So I'll take a reverse quick rapid fire on innovation. So since we have been talking about innovations in this particular session organized by ICMR, so Leena, what would you suggest? What innovative practices needs to be sort of initiated to tackle AMR in low middle income country?
So I think one of the biggest learnings that comes from our own work in various areas of disease is that, you may have a good pipeline. For example, in diagnostics, you might start having a good pipeline. However, you need implementation research and uptake by procurers. And I think this is a big challenge from innovation to bedside. How do you may have, for example, today we have XDR diagnosis for TB available. You can do fluoroquinolone resistance in one go along with the rifampicin. You can even do injectables. But how do you get the chips that go into these machines actually be procured by the TB program and available to patients? And I think this is where we need a sort of a guideline where it says, okay, we're getting this innovation. we're getting it into guidelines, and this is all time bound. We are getting it into procurement systems, and then we're delivering it to patients. And I think this is where, from innovation from the labs to the bedside is a big challenge. The second thing is what it really very clearly shows, that only when you work as a network in a collaborative way, sharing your data and sharing your scientific capacities, is that where you are able to deliver more effective innovations. And when we had Otsuka and J&J work separately, we didn't do so well, but now everyone recognizes in TB, you're going to go together. I think where countries are developing these platforms for diagnostics and drugs and doing, collaborative platforms where everyone from the private and the public sector comes onto that platform and shares resources and data, that's when your innovation actually starts making a dent, in terms of guidelines and implementation.
Yeah, truly said. I think that is extremely important, and ICMR has really taken a huge lead in creating those collaborative and consortium. And the inclusion of this gene expert within this TB program was such a big step. But thanks to that, there is a lot of identification. So, Dr. Rakesh, what would you feel? How would we take this, as Leena mentioned, innovation to the bedside to tackle AMR?
Yeah, so I think when we talk about TB and a few other specific, advances in the diagnostics, I think I would still feel that whatever we know, I think it's more about implementation, research, and making people practice what we already know. Just to give an example, so you could have a molecular test or a panel, a multiplex panel to pick up viral infections and respiratory tract. Now, I think we may be using it, we may get a certain pathogen and so on, but what we need more importantly is to know whether the child or the person has a bacterial infection or not. Now, very often, again, the issue around diagnostic stewardship has to also come into be there. Apart from that, I think it's just trying to get people to use the knowledge and what we already have. Maybe we need better clinical decision support systems at hand. I would think that even the apps that we are talking about and a couple of examples, and including one of our own, they are more like converting I would say, a handbook or a textbook into an app. I don't think so that really serves a purpose completely. I think you need a more directed kind of a situation where you don't really need to read the theory. For theory, you could always go to the books. And also, I think we need a little bit more user-friendly perspective on some of these applications so that people actually get down to using this in an appropriate way. The rest would be, I think, just assisting this clinical decision-making and diagnostic stewardship. Thank you.
Thanks. I think you rightly mentioned about the CDSS and the app. We'll talk more about it because you have worked so much, and we know that that is making wonders in your setting. So, Dr. Camilla?
I think diagnostics for AMR is clearly an example of unexploited turf. And to this end, I think ICMR has taken a step in the right direction by they have a task force on AMR diagnostics. They're asking everyone, look, guys, come, you present something to us, something that's worth it. We're ready to get it validated. And if it works, why not? So there have been some applications which we're looking at closely, because the task force is actually developing validation protocols. They have a TPP, a target product profile for diagnostics, which is really one of the pretty good thing to start off with. And they're also looking at cost effectiveness for diagnostics. Now, you can't have a diagnostic. I mean, we all use syndromic PCRs. They cost 10,000 rupees. I mean, how is every Indian ever going to afford it? So cost effectiveness has been played into this, AMR diagnostics, which is really a laudable goal. And I think that's the only way we will get it. Gene expert, Leena spoke about gene expert, but why is it being used out in the field? Because it's cheap. Even the private practitioner is using it, and the cost in the USA is $55. We're getting it for 10. So ultimately, whatever you say, cost effectiveness is the bottom line. And I think that's the way we need to look at stuff.
I think you brought in a very important point of economic analysis, but whatever work has been done by this task force is phenomenal. Dr. Rao, I'll end with you. Quick input on what could be done.
Sanjeev, I'll look at the whole spectrum of the stakeholders. We normally feel it's only the clinician who's not using it or using it, but let's look at all the stakeholders in this. government is there, policy is there, market is there, manufacturers are there. So everybody should be involved only with one purpose, that it should be available at the bedside. Secondly, we know that 60% of the hospitals in India are less than 40 bedded. If we ever think that these hospitals are going to put in resources towards the diagnostic workup, then we are mistaken. So collaboration and some kind of innovative access supported by either the industry or the government or the state government, whosoever, is going to be the way out. Because all these hospitals cater to thousands and thousands and thousands of patients, and they give left, right, and center antibiotics without any diagnostic workup. So we focus largely on the large hospitals, but I think we should not leave these big chunk of hospitals, smaller hospitals out.
Thank you, sir. I think that's the lead which, again, Dr. Kamini had taken of hand-holding secondary care institutions. So that's a big contribution to the society. And you rightly said that. Dr. Kamini?
Yeah, thank you, Dr. Sanjeev, and thanks, Dr. Rao. In fact, I'm grateful to all the PIs actually who are working with us in hand-holding secondary level hospitals, because these hospitals do not have laboratories. During this project, actually, I came to know that there is not even a single NABL accredited lab in some of the two-tier cities which get so much tourism. I would not name the city here. But I have a question for Dr. Rao. Sir, I really want you to wear your NABH hat for now. And NABH actually recommends very strict infection control practices as a part of hospital accreditation. What are your views on incorporation of such strict standards also for antimicrobial prescriptions? And how do you think innovation can actually facilitate that, any kind of a technological innovations?
Dr. Kamini, as you know, accreditation is a voluntary effort. So there is no regulator involved in that. And we work on the premise of incentivizing. So
Okay.
whosoever kind of, comes on board ultimately gets an incentive in terms of the reimbursement, in terms of the empanelment that they can be on. So we largely work on that concept. And what we believe is that on no given day, we will say that, all right, now you meet everything and yesterday you didn't. So we have kind of a pathway laid out for them where we say, all right, these are your core competencies and these are the desirable things. And this is what will cause excellence. And this is where we want you to be an achiever. So in the achiever and in the excellence model, we have that, okay, if you have prescription audits, then you are an achiever. If you can lay down a system in which you can help the clinicians to write prescriptions properly, then you probably are in the excellence group. But there are certain core elements, and core element is one, that your prescription should comply with the best guidelines of writing prescriptions. And then in the objectivity, then we bring in that, okay, the manner in which you write the content, then signature, date, and all those things should be there. So that is how we kind of assess the hospitals. And I think this is the right way, because not everybody is going to be 100% compliant. So we have created a list of desirable.
Yeah, but I think extending that list, incrementally should, because now that we are so concerned about extensive broad spectrum use, so every step must be initiated to kind of reduce and, as you very rightly said, incentivize hospitals to deliberately shift from broad spectrum to more of a narrow spectrum antimicrobials.
So what we are doing is we are creating a separate category of excellence and a separate category where they are achievers. So this is where prescription audits are going to take place, and their reimbursements probably will be higher than the others. So we work on incentivizing the effort that the hospital puts in, and that ultimately helps our cause.
Thank you, sir. So, Dr. Camilla, you have had extensive experience of working with TB in the country, and you are also actively part of the AMR related research. So how do you think, we can bring more clinical microbiologists on the board so that they are able to provide that 24/7 support in ICUs. Because right now, in many places, we see that the labs do not really accept samples after 4 p.m. And then the results are not available for almost 48 hours after the culture is sent. So how do you think, this can be incentivized at the level of hospitals? Because hospitals have to invest resources in strengthening the clinical microbiology, strengthening the infection control. And unless we really improve the diagnostic stewardship and the infection control, we cannot think about strengthening antimicrobial stewardship.
Absolutely. I think one takeaway message from this webinar should be capacity building for AMS, and IPC has to be absolutely, I cannot overemphasize the importance for it. It's like, you're trying to put out the fire without knowing what caused it. And if we focus even on good stewardship, if we don't prevent it with good infection control practices, you're going to land up in the same problem as you did. So infection control somehow, clinicians feel it's for the nurses. I mean, we are great. Our hands are fine. Nothing to worry about us. But slowly, as they are coping with resistance, they're beginning to realize the importance of it. I remember years ago, I had given a talk on perioperative prophylaxis, where we were actually, I was telling the surgeons to please use first generation cephalosporins perioperatively. And at the end of it, they all said, "Arey, theek hai, for Hinduja, it's okay." For us, our instruments are not sterile. We don't know. We are not sure. I said, man, you can't blame the unsterile equipment for giving a high-end antibiotic. You just start up front and get those sterilized immediately. That is the basic premise of surgery. You can't use poor infection control as a reason to overprescribe. And I think that is what everybody should realize. You can't overprescribe in the nursing homes that we see. I mean, you feel like running away when you just enter them. So I think the secondary nursing homes have to kind of put in place mechanisms to invest in infection control. No question about it.
Thank you. Thanks, Dr. Camilla. So, Dr. Lodha, your hospital was your department in your hospital was actually one of the first departments to implement the antimicrobial stewardship program, and then also to have a mobile application or a guideline which could be downloaded. What difference did you think it made, and what kind of support do you think was available for the antimicrobial stewardship at that time when it was started?
Okay, yeah. So thanks, Dr. Kamini. I think just a couple of things. So we developed we developed the antibiotic policy for the department, and as a job aid, we developed an application which is available only to the the residents and people working here, because for a very simple reason that most of it relates to the infections, let's say the infections acquired or the healthcare associated infections. And therefore, what we have an antibiotic policy may not be applicable to another institute. And therefore, we need to keep this in mind when we talk about any apps or any guidelines which are there for prescription of antibiotics. We could certainly have some kind of guidance based on what is community acquired infections, and that could be more universal. We could also have, let's say, maybe coming from the network or the participating institutes in the ICMR surveillance study, one could have, maybe regional kind of guidelines, and maybe there's a fair likelihood that the guidelines may appear similar. But the very basis of having an antibiotic policy or prescription guidelines based on your antibiograms makes it loco-regional kind of apps and not really universal apps. Now, having said that, the app that was put out from the institute is more like converting a guideline or both diagnostic and what should be your antibiotics as a job aid, in terms of having that similar material available on an app which is easy to carry for the residents and refer to it as and when one is needed, rather than carry a handbook or a book in particular. Within the department, as far as the antimicrobial stewardship program, I think we are using it more as an educational and a job aid for a resident who's managing a patient on the floor. And periodically, when we look at the antibiotic appropriateness of the prescriptions, I think we find that we reach somewhere around 85 to 90% after we have had this. So I think this just serves as another tool to improve the antibiotic prescription. The basis, of course, would have to be sound clinical judgments around what we're doing, particularly when we talk about the empirical antibiotic therapy. The rest of it, I think, if every institution should have a mechanism based on their data, and I think that would predominantly be applicable to tertiary care to begin with. And as the microbiology services improve and the reach improves, I think even the secondary level institutions or a group may be able to have their own applications. Yeah.
Thank you, Dr. Loba. Dr. Singh, you have anything to add? Because your hospital also has been implementing the AMSP program for a long time.
Yeah, I think ICMR did help us with the sepsis registry program, and we developed an app on 1 hour, 3 hour, 6 hour bundle. We also have our own antibiogram and app-based antibiogram, and we are a university teaching hospital. So we thought that undergraduates would use it when they are prescribing, when the patients come at ER. What we have realized is that it is good to have an app. It looks, forgive me my saying, but it looks sexy. But the usability it's very poor. 18% of our undergraduate, postgraduate were only using it. So making an app is one, and making it inspiring or exciting for use is, I think, the second portion, which also needs to be focused.
Thank you, Dr. Singh. So, Leena, you have been very closely associated with the TB program, and how do you, and you are also now witnessing, how the things are changing in the AMR space. So, what we are missing out in AMR space is largely the engagement of the community. Community piece is almost missing. Most of the discussions are between microbiologists, or at the most now we have started engaging the physicians as well. But how to get about getting the community to feel part of this whole narrative and the challenges, and also kind of getting them to help us with the containment efforts.
So, I mean, there's no doubt about the fact that some of the successes that we are seeing in viral hepatitis or TB or HIV come from the fact that you have community involvement in, involvement in all aspects, from guideline development right down to implementation. So I think one of the things I would really highly recommend to ICMR is to sort of map certain groups that work on health. You could look at gender and health as an area where you could present the whole issue of antibiotic resistance to the groups working on gender and health. And of course, I could name a few more. What it helps is that they start becoming more alert, and they start monitoring the state AMR plans. And then they come back and actually ask for more things. They say, well, you're asking for antibiotic use based on diagnostics, but we don't have diagnostics in this district. And I think that's where I think we could really change the game on antibiotic resistance, is by taking people who may know nothing about antibiotic resistance and working through them to, start, challenging the whole dilemma of AMR. And I think you could start with gender and health. You could start with a number of other groups. I was talking to groups that work on men who have sex with men, STIs. And they were telling me about the challenges that they have with drug-resistant STIs. So you have many, many groups who are concerned about antibiotic resistance, but they are not in dialogue with ICMR and other experts who are working on antibiotic resistance. And we could start with a few groups across the country and call for a national consultation and present this whole issue in a way that's much more easier for them to start looking at. And then actually, majority of the funding today internationally flows to certain networks, tech networks. It doesn't flow to community. So you could just change the dynamics by holding a workshop and bringing in these groups who are concerned. I think women's groups are definitely concerned about, UTIs and how drug resistant they've become. So we could just start the dialogue and start mapping who would be our allies in making this more, something that matters to all of us and not just to the experts. Yeah.
Over to you, Dr. Sanjeev.
Yeah, Leena, I think you mentioned a very, very relevant point, gender in health. And if you look at cancers, the ladies, they are mostly working in house and they don't come up with any of the preventive health program, and they reach to the hospital when they are very, very sick. So very relevant point. I think that's another big area, and possibly the gender consumption, the antibiotic consumption would have a different ball game here. So important point. So I'll ask Dr. Rao, because you have been the chairman and you have done so much of good work in your institution and in the Society of Critical Care. Dr. Kamini did ask you about the role of NABH. There is a one full chapter on infection prevention. NABH started a program called SAFE-I, just looking at chapter 5. Antibiotic stewardship got added in the 5th edition. Dr. Kamini was mentioning about this prescription, and you mentioned about prescription audit. So can we do anything more concrete, more relevant, more targeted with prescription for antimicrobials?
No, the prescription that we are saying does include the antimicrobial. Of course, it's not limited to antimicrobials. But at some point of time, after all, we are still in a stage of flux where we are trying to inculcate this habit of getting accreditation among the hospitals. Not every hospital we have on board, and not everybody at present is willing to come on board. So, we are going in our own, tempo, where we feel that it is always good to grade the hospitals. In that sense, some are leaders, some are innovators, some of them are laggards. So while in NABH, we can't focus on one particular category of hospitals, we do want to bring in the centers of excellence, which will be defined differently than the rest of the hospitals. And probably their reimbursements and their privileges and their market positioning is going to be very different. So it will act as a stimulus to to others to come on board in that kind of marketplace. That's our strategy at present.
But congratulations to you. You have done phenomenal work in incentivizing, and that 15% gain also promotes people to get accredited, and that's a good start of quality journey. Dr. Camilla, you are the, I think, queen of microbiology, and you are the people would look at your advice, and then you have been such a great inspiration. We are talking about innovation to bedside. How do we get all microbiologists at bedside, away from the lab, helping the clinical work and helping in the clinical decision making?
Microbiologists really want to be at the bedside. Whenever you ask them, they say, we really want to be. So it's the clinicians who need to invite them. If you just see a microbiologist sadly standing by the bed and the clinician not noticing, the clinician has to actually value the microbiologist and say, hey, why don't you come on rounds with me today? They'll be thrilled. They'll be so happy to contribute. That's one point. And the second point is Dr. Lodha did actually say that the data that we collect and we put into a cumulative antimicrobial antibiogram is what is the basis of our antibiotic policy. Now, we were doing that for years till we started actually teasing out the data, and ICMR helped us a lot in that. We started looking at every susceptibility test and calling up the patients, finding out the patient risk. He had antibiotics in the recent past, had he was hospitalized, had he comorbidities, had he any invasive devices. We looked at the site he had infection. We looked at whether he was hospital acquired or community acquired. We looked at at so many other factors. And when we came up with our antibiotic policy site-wise, we find that it makes so much. For example, just to put into perspective, a patient who has no risk comes into our ICU now. with the pneumonia, we get strep pneumonia as our first organism causing the etiology. Earlier, we were getting as Klebsiella. It was just that we were not stratifying it according to patient risk. And that is so important because ultimately, the clinician compliance is going to be depending on what you put in the policy book. If you put Klebsiella as your first most common organism, they'll be forced to start up front with an antibiotic that is going to target Klebsiella, which is a resistant bug. So, stratifying your policy as per patient risk we found is really, really changed. And another thing is when we put it out, it's a buy-in by, they have to sign out on most of our clinicians. Our ID physician will say, no, can you look at this more closely? So it has to be a buy-in from the clinicians as well. Ultimately, the AMSP is being driven by a clinician. We are helping them with the policy. And a pharmacist is terribly important to monitor how things are going on.
Yeah, I think you.
Dr. Sanjeev, can I add?
Yeah, please.
Here? What Dr. Kamala said is fine, that the clinician should invite the microbiologist, but we all know that that is not happening. And one of the reasons is that it doesn't make a difference to the clinicians. When in NABH, our approach is through the management. We do not reach out to clinicians directly. We reach out to clinicians through management. And the management is sensitive about two things. One, their branding, and the second one is their reimbursements. So if through NABH, we can get these things to people that, okay, this hospital is good because of this thing, I'm sure the management is going to enforce that microbiologists are involved in the decision making. Because leave it to the physicians, they will not involve the microbiologists as it stands today, because they think they know all.
We can also have comments from Dr. Lodha because he comes from the public sector hospital. Right now, we have only heard the private sector hospitals. Dr. Lodha, on the same.
Yeah, no, I think this collaborative effort has to be there. And I think this needs to be encouraged. And I think we all would have our own reasons for this not happening on a regular basis. But in pediatrics, a few years back, we did have this combined rounds, wherein we don't want, maybe not for every single patient who's admitted with us, we want this consultative process to be there. But we need, wherever we are finding it challenging to treat or the infections are difficult to treat, I think we need to get that. Just like it's, I think, something like what we have as a radiology conference, where we pick up more difficult cases and discuss with the radiology team. I think we need something similar. Now, the issue is about whether going to the bedside really helps or not is an entirely different issue. I think what is more important is the consultative process. We could do it sitting in a conference room with all the data that you have, presenting it to them, and the microbiology team coming up with suggestions around, both about maybe the diagnostics as well as what suggestions could be there in terms of, modifying the management and those aspects. Going to the bedside, I think, may be helpful in a certain way to get another perspective. I think that's about it, but I don't think so that should be mandatory that you need to round. Again, it depends on the staffing that we have. Most of the times, I don't think so the staffing would allow regular rounds by microbiology team in clinical areas and so on. So I think we need something which is doable and sustainable. Thank you.
Thank you. Dr. Sanjeev, you have any more questions? Or
My last question to Leena, I think there has been Dr. Rao, Dr. Kamila mentioned about clinicians' perspective, and they need to buy in, and we are talking about microbiology rounding. Is public or is community important in this whole game of antimicrobial as a public health agenda?
Yeah, so I just simply want to say this, that, what changed the game for HIV and TB and even viral hepatitis was the fact that communities took up treatment literacy for themselves and can actually challenge treatment providers and say what you're prescribing to me is not the correct, protocol. And we saw that in antiretrovirals, where patients would say that I don't want to be on a stavudine-based regimen because it causes neuropathy. And I think clinicians in the HIV program were completely shocked that actually patients were coming up and people living with HIV were coming up and challenging them and saying they're safer drugs to be utilized. And I think this is where I think communities play such a tremendous role, is that they take up something which is couched in very technical terms and turn it into treatment literacy and then turn it into holding the system accountable. And I think this is where the role of community-based models are so important, that we start looking, we've started very well with tertiary care models. Now we need to move into the community-based models, and that's the big challenge. Where do you start? Do you start with the ASHA workers? Do you start with the civil society groups that work on health? Do you start with vulnerable communities who've been affected by drug resistance? Where do you start? And I think a proper mapping and calling of stakeholders, key stakeholders, would be very useful. Because in my experience, they start moving the machinery for clinicians and policymakers very quickly. So the role of community, I just cannot sort of highlight enough. The women I have been talking to about getting a culture test before you get yourself a round of antibiotics for your urine infection are the ones who have challenged clinicians and said, I'm not going to start my antibiotics on day one. You can give me something for the pain relief. I'll come back on the third day for my culture report. And the thing is that, patients are demanding antibiotics, but patients don't have the information to challenge the patient-doctor equation. So I think this is where communities can play a tremendous role. They can equalize the power equation between the treatment provider and the patient. And I think this is where I would say that one of the recommendations on the national AMR plan, which was to set up something in the MOH that would look at implementation, is where does IEC come from? Where does information, education, counseling, where does technical support come from? It comes from the MOH, the central MOH, And funding to communities, where does it come from? It comes from, programs like HIV, TB, who have been funding these community-based organizations. Of course, you've got the global fund over there. If you don't have a coordinating mechanism within the Ministry of Health, that's where I think we are going to all struggle. Because, we can do an excellent technical job, but then you need the MOH out there funding communities, making sure the new innovations are taken up, and working with state governments to provide them what they need. And I think this is where I see a glaring gap. I'm not recommending a vertical program. What I'm saying is the MOH recognize that there's an implementation part of the AMR plan. And that implementation part belongs not just to ICMR, but it belongs also to the MOH. And I think we can't do all of this without MOH stepping in with some kind of plan, program, whatever they want to call it. Yeah. I'll stop here.
Thank you, Leena. Indeed, antimicrobial resistance is a very big public health challenge, and we have only made a small beginning by starting at the tertiary care. And the reason we started at the tertiary care was that there were labs there. So it would be very difficult to go forward without having a diagnostic support at different levels of healthcare. And that's what we are trying to, achieve through the multiple initiatives that we are undertaking, engaging with the secondary hospitals, having a AMR diagnostics task force. So it is a very big puzzle for us. We all have to find the pieces that fit well so that we are able to make some progress. But indeed, I think whatever we have done so far, it has gone in the right direction, and we should be continuing to take those small steps so that we keep making progress. So I now request Dr. Ram Gopal Krishnan. He has been the chair of our antimicrobial steward, the committee on guidelines for antimicrobial use, and has reviewed and supervised creation of the guidelines which we have released in the past, including the management of carbapenem resistant organisms, which was released this year. And in fact, it was his idea that ICMR should create a downloadable application which is available to all the clinicians on their phone. So we are indeed grateful to you, sir, for providing all the support and all the ideas, and we look forward to your continued support. Your remarks at the end of the session today.
Yeah, thank you very much, Dr. Kamini. So this was a very productive couple of hours. I remember when ICMR first came to Apollo about a decade ago, Dr. Kamini and Dr. Ori, and said, we're going to start this national network for monitoring. I thought it was a step forward, but I was wondering how they were going to achieve all this. And certainly they've come a long way in the last 10 years, just from monitoring and collecting data to production of guidelines. There's an adult guidelines. There are guidelines for resistant infections. Now there's a pediatric guideline being set up. And the second part of it was how to get this out to the doctor. And this struck me actually when I was rounding in a very big charity hospital in Karnataka. The doctor there was actually opening the AIMS app, which I'm not sure if that's the one that Dr. Lodha put out or something else, and looking up how to treat a common infection in the emergency room. And I thought if somebody can do that, and if we can get this ICMR data out in the form of an app, that would be the best way to reach every clinician in the country, because that's the way forward. And I think this is a good step forward. It'll be a challenge to stay updated. It'll be a challenge to incorporate, moving resistance as well as clinical research into the app. You'll have to update that frequently, but that's certainly the way forward. And hopefully ICMR can facilitate this and take this forward. Thank you very much.
Thank you. Thank you, Dr. Ram Gopal Krishnan. And thanks everyone who joined. And I'm sure we all learned something today, and you will be able to put the guidance that you got today into your clinical practice. So we have launched this app today. It is available on the ICMR website under the guideline section. The QR code is there. And thanks to Dr. Harpreet and his team who have worked hard to get this application together. And this would not have been possible without their support. I would also like to thank all the speakers and the panelists today. I have been working with most of them for a very long time. And I would like to acknowledge their unconditional support to the ICMR initiatives. And I owe the progress that we make on AMR to the guidance and advice of all these experts who were part of this today. And I also like to thank my entire team who has worked behind the scenes to put together this webinar together. And today, after hearing the discussions, I think we should be having more of these consultative webinar groups, probably the syndrome-based something, because I realized when Dr. Ram Gopal Krishnan mentioned that, this cannot be summed up in 15 minutes. These are 2 books. So probably we should have syndrome-based consultations where we can bring more clinicians to talk about the management and also antimicrobial prescriptions of these syndromes. So this we will discuss internally with our expert group, and we will definitely come up with some of these sessions in the next year. So thank you so much for your support, and I hope that these deliberations were useful to all those who attended it. Thank you.
Thank you,
Thank
Dr.
you, Kamini.
In case
Thank
we
you,
are not meeting before the end of the year, a very happy new year to all of you.
Still long time to go.
Right.
Just a month left.
Yeah, 4 weeks. Thank you, everyone. Thank you so much.
Thank you, everyone.
Thank you, Kamini.
So much. Bye-bye. Oh, man.